In this weakness video, we're going to cover the things that are the highest yield that cause weakness. This is by no means an extensive list, and if what you want is an approach to weakness that considers more of the diagnoses that can cause weakness, check out the intern content. We're going to talk about the demyelinating diseases and then also the neuromuscular junction diseases as a way of talking about those diseases that can show up on the test because they are so clearly obvious in the vignette. We'll finish with ALS because it's gained popularity in the press and it too has a very unique presentation. Let's start off with those demyelinating diseases because that's what you need to know the most about. We're going to start off with multiple sclerosis. The pathology of MS is that it is an autoimmune disease. It generally affects women, and as we said, it is a demyelinating disorder. What you're looking for is a younger woman in her 20s to 40s, and she is often a female. The multiple sclerosis is very difficult to identify on this presentation because it can affect anywhere in the brain and the spinal cord. It can cause literally any neurologic symptom at all. You'll see this stick figure used throughout this course to represent what you should remember about the location of the disease. The problem is, in MS, it's a big question mark. So you're looking for any neurosymptom that is separated by time and space. For step 2, the variants of MS don't count. The one you're looking for is the relapsing remitting variant, such that someone will have one neurologic symptom at some point in their life, and then later will have a different neurologic complaint, separated by time, and the symptoms cannot be correlated to one structural lesion, separated by space. If they want to give you, this is the first diagnosis of MS, what they will give you is optic neuritis. Because there's an itis, it hurts when they move the eye, and the eye will be blurry. Blurry vision and painful movements, optic neuritis. If you have any other neurologic symptom in time and space, it's multiple sclerosis. Now, if you suspect MS, the way you do it is with an MRI. MRI is both the first and the best test. And what you're looking for is periventricular white matter. You're looking for plaques, which are shiny white, and things next to the ventricle wall. On an MRI, periventricular white matter or plaques, that's MS. Now you might have other options, and these can be done when the MRI is inconclusive, but for the test, don't do them because they're neither sensitive nor specific. A lumbar puncture is going to show you oligoclonal bands. Oligoclonal IgG. Don't get this because the MRI is better and first. You could also do evoked potentials. It's going to show you that there's demyelination. Great. Don't do it because the MRI is first and best. Only in the case where the MRI is inconclusive should that be the test of choice. So once you've diagnosed MS, how do you treat it? The first thing you need to be able to recognize, because this is what you'll see in the hospital and what you're most likely to be asked on the test, is that if someone is in an MS flare, you treat them with steroids. Very much like lupus, MS can be triggered, that is, the symptoms can come on when someone is infected. So rule out an infection first, and if you say this is an MS flare, give them high-dose IV steroids, usually over 3 to 5 days. But once the flare is over, that is, an acute relapse is over, you can't manage them on steroids. So you'll have some chronic management tools. I don't want you to remember the whole list, and there are 12 of them, but the ones you should be able to identify on the test because they've got strange names, and if you see those names in the answer choices, you know the question is about multiple sclerosis. So look for interferon. That's the one that we know works best in delaying progression. But also look out for glatiramer and fingolimod. Don't commit them to memory so much as to be able to recognize them as those are the MS drugs. Where the test might also go is to assess your ability of managing the complications. Because this is not unique to MS. So if you have urinary retention, you can use bethanechol. Bethan, call your bladder and tell it to move. If you have urinary incontinence, what you can use instead is amitriptyline. If you have spasms, use baclofen. And if you have neuropathic pain, gabapentin. Now, are there other drugs to treat these things? Of course. This is what I want you to commit to memory, so it's 1-to-1. You can use cyclobenzaprine for spasms or pregabalin for neuropathic pain. But if you keep it 1-to-1, you'll get the answer right on the test. Lots to know about MS, but what you're really looking for is neurosymptoms in a female, separated by time and space, get the MRI, give her steroids. If you know she has MS and you've ruled out an infection, you don't have to get another MRI. You can just treat her with steroids. This is the first time she's presenting. Before you commit her to high-dose toxic steroids, get the MRI. All right, the other demyelinating disease is not nearly as complex, and that is Guillain-Barré. Guillain-Barré is an autoimmune disease. It is demyelinating. But it is very different than MS. In Guillain-Barré, you have ascending paralysis. It starts distally and begins to ascend towards the trunk, and eventually may reach the diaphragm. If it reaches the diaphragm, the person doesn't breathe and they die. The patient is going to present after a watery diarrhea. Usually it's Campylobacter that's implicated, or a flu shot. And then they have an ascending paralysis. And this is key, they must have hyporeflexia. There may be some paresthesias, but usually sensory is spared in Guillain-Barré. So what you're looking for is someone who has diarrhea, paralysis, and hyporeflexia that's in the legs working its way up. If that's the case, the diagnosis is made by lumbar puncture. It will show lots of proteins. You have the immunoglobulin that's causing the autoimmune reaction, but very few cells. Lots of protein, very few cells, that's Guillain-Barré. You could do other tests, such as an MRI. It might rule out some other diseases, but isn't helpful for Guillain-Barré. If you do an EMG, yeah, you're going to see a demyelinating disease, but lumbar puncture is first and best. Notice the difference between it and multiple sclerosis. The treatment for Guillain-Barré starts with intubation. If the person has ascending paralysis to their diaphragm, it doesn't matter what else you do, you have to intubate them. So before you get the lumbar puncture, if you're thinking this is Guillain-Barré and they're having trouble breathing, intubate them. But once you've made the diagnosis, intravenous immunoglobulins is effectively the same as plasmapheresis. And you never give steroids. IVIG binds up that immunoglobulin. Plasmapheresis simply removes it. They are the same. Steroids generally worsen the outcome and the relapse factor of Guillain-Barré. These are our two demyelinating disorders. Let's now talk about those at the neuromuscular junction. And to do that, we need to look at the neuromuscular junction. That's a presynaptic neuron. Here on the end plate are acetylcholine receptors, ready to accept the acetylcholine that's stored in the presynaptic neuron. Those presynaptic neurons are stored there until calcium channels open in response to a nerve conduction down the nerve. And you have a whole bunch of vesicles sitting there, full of acetylcholine ready to go. If you contract and you use them, it takes time for the cell to reaccumulate them. The more stimulus the end plate has, the more likely it is to release those vesicles. You must be like, why are you telling me that? It's important to differentiate myasthenia from Eaton-Lambert. Let's take a look at both and you'll see what I mean. Myasthenia gravis. It is an autoimmune disease against the acetylcholine receptors. You're almost always going to see it in someone who's over 50. The antibodies, what they do is effectively block the acetylcholine receptor. If you block the acetylcholine receptor, you need a lot more acetylcholine in order to get that receptor to work. Right? You have to increase the concentration so that the acetylcholine outcompetes the receptor. Now again, you have a bunch of acetylcholine sitting there. So there's no problem in getting these calcium channels to activate, so a whole bunch of acetylcholine goes out at once. A contraction occurs. But with repeated stimulation of that nerve, repeated contraction, there's not a lot of acetylcholine left, and then the antibodies begin to win. So what you have in myasthenia is fatigability. And the muscles that are going to be fatigued are the ones that you're going to use the most. And you're going to be surprised by the answer. It is generally going to be the eyes, the throat, and the fine movements of the distal extremities. Blurry vision, difficulty swallowing, lack of hand coordination, that's because you've depleted the acetylcholine at the end plate and it begins to fatigue. And it will be worse in the evening. To make the diagnosis of myasthenia, you want to get the antibodies. It's going to be the anti-acetylcholine receptor antibody, and sometimes, in very small amount of cases, the MuSK. Don't remember MuSK, get the acetylcholine receptor antibody. To be certain that this is the diagnosis, you get an EMG. What you're going to see is great amplitudes that begin to fatigue off, and then they don't contract anymore. That's because you've depleted your acetylcholine receptors. And here's where you score bonus points. On myasthenia, get a CT scan looking for the thymoma. The majority of patients have a thymoma when they have myasthenia. To treat myasthenia, you want to do two things. You want to increase the amount of acetylcholine. You do that with cholinesterase inhibitors. The thing that breaks down acetylcholine is blocked. Be careful though, because it causes an increase in secretions, and if they're already having trouble swallowing, they might end up with more secretions in their lung. But you also want to decrease the autoimmune component. So in cases that are not controlled by the stigmines, pyridostigmine, for example, you use steroids. This is in resistant disease. If they're in a myasthenic crisis, that is, it's so bad they can't swallow or they're having trouble breathing, then you can use IVIG, which is equal to plasmapheresis, in a myasthenic crisis. And here's how you get bonus points. You found the thymoma, remove it, doing a thymectomy might actually be curative. If you understand myasthenia and the explanation we had up here, Eaton-Lambert's much easier. In Eaton-Lambert, you have an autoimmune disease that's often a paraneoplastic syndrome. And you have antibodies against those presynaptic calcium channels, which means that it is harder to release those vesicles. The end plate on the other side has free receptors. Inside the presynaptic neuron are a bunch of vesicles full of acetylcholine. They only need the signal to release. If you block the calcium channels, you need additional signals to get it to move. So it is literally the opposite of myasthenia. They'll still be 50 or older, but rather than fatigability, they'll have improvement with use. And because they have improvement with use, the muscles you use the least are going to be the ones that are the worst. And that is generally going to be the proximal muscles. And proximal muscle weakness, you're going to hear things like the inability to rise out of a chair, having trouble combing their hair, or getting things down from a high shelf. Things that involve the proximal muscles that may have been sitting in a chair for a while, and now they actually need to engage them over and over until this weakness is overcome. So if you're going to diagnose them, not surprisingly, you want to look for the antibodies, and the EMG is going to be the opposite of myasthenia. You're going to start off with not that much contraction, but as you get more and more attempts, the amplitude of the muscle increases. And just like myasthenia, bonus points get that CT. What you're looking for is small cell lung cancer. The treatment for Eaton-Lambert is to treat the cancer. Chemo and radiation because it's small cell, and if it's not small cell lung cancer related, you can use immunosuppressants that you encountered in the rheumatology section. Things like azathioprine or 6-mercaptopurine. I don't want you to remember that for this. All I want you to know is that if you see proximal muscle weakness, think small cell lung cancer. We're going to close with ALS, only because it's easy to spot and it has gained some press. Now that superoxide dismutase thing that you'll learn about for step 1 accounts for only 10% of cases. It is sporadic mutation that happens to cause ALS, and the reason why the test likes it is because it is a combination of upper motor neuron lesions and lower motor neuron lesions at the same time, usually sparing sensation. A lower motor neuron lesion will have areflexia, weakness, and fasciculations. An upper motor neuron lesion is going to have hyperreflexia with weakness. Since you're going to have multiple lesions along the spinal column, different limbs will do different things, and Babinski might be different left to right. You can't correlate the symptom to a central lesion, nor can you correlate it to a single lesion in the spinal cord. Also, sensation is spared. The diagnosis is made with an EMG, and the treatment is supportive. These patients die because eventually all their muscles fail and they can't breathe. Riluzole is a medication that gives them 3 months to live. I know this was a long one and there's a lot of detail, but we parsed it down to the must-knows for weakness. Multiple sclerosis, young women, neurosymptoms in space and time, get the MRI, treat with steroids. Guillain-Barré, watery diarrhea, get a lumbar puncture, treat with IVIG or plasmapheresis. Myasthenia gravis and Eaton-Lambert diseases are the M-plate diseases. Myasthenia gravis, thymoma, fatigability, small muscles, cut out the thymic mass. Eaton-Lambert, paraneoplastic syndrome, improves with use, therefore the proximal muscles are affected the most. And don't forget about ALS, which has a combination of upper and lower motor neuron lesions. That is weakness.